nurses. We also do the same training in the ER department. So we set an objective for our study to determine the knowledge and views of critical potential donors. We had questions. It was a small in-house study, and we distributed and collected the post-test. And we had 173, and the post-test had the same 10 quantitative questions with 3 additional 6 for critical care professional nurses, and were reluctant to refer due to gatekeeping and other barriers only learned of, and we asked them for recommendations. Questions. We identified 3 themes. That it is an international problem as well. Request training intervention can be used by other transplant coordinators, the questionnaire and the PowerPoint.
Thank you, Mr. Chairman. I would like to give you about liver transplantation for hepatocellular carcinoma. It's the 5th cause of cancer-related death and cancer, with a 5 years overall survival of over 70%. The recurrence after liver transplant affects long-term prognosis, and the incidence is greater when the liver transplant is in the time of transplant at 99 days. It's interesting because the implementation of the MELD were done with total whole liver grafts and 24 with partial grafts patient time of transplant. 29 of them were within UCSF and 27 were beyond UCSF. Post-transplant pathology, 18 patients, 10% criteria. When compared with patients into my line criteria, and this is what we are working now, 2003 or 4 that we have available sirolimus or everolimus after in our country, patients were all on FK. Once we started with the using everolimus or sirolimus, we put them on FK for the first month, and then we switched them over to everolimus or sirolimus. But we have not found any significant difference in terms of recurrence, free survival, using one or the other medication. That's why we didn't include that in the analysis.
Okay, thank you. And the other things, I'm wondering, do you have any experience non-HCC tumors for transplantation?
Yes. We are for the first center in Argentina transplanted neuroendocrine tumor patients, and we have so far not many, 4 patients who we have been transplanting. The 4 of them are alive with more than 3 years survival, and only 1 of the 4 patients have recurrence of the disease, not in the liver, they have disease in the lungs. Now, when we analyze the origin, which is against of what we have published before, is that the patient who had recurrence was a case of intestinal primary tumor, not pancreatic primary tumor. From the 3 patients, 1 only has a tumor on the tail of the pancreas. Now, we had a very strict policy for transplant those patients. When the world is usually recommending to transplant them when they have a Ki-67 rate more than 10%, we only apply criteria for transplant on those patients who have less than 2% of criteria, because we found that the survival when you have more than 10% is disease-free survival is lower than 50% in the long term. That's why we decided to establish a very selective protocol, and we were able to give to them the same amount of priority criteria than HCC patients to get further up in the waiting list.
Thank you.
One last question, I think. Do you have the liver resections done in this group of patients rather than transplant?
We have, I don't remember exactly the percentage, but our program is very aggressive in terms of treatment. We use chemoembolization in all of them. The patients who have child A and up to B with the small tumors, we favor resection and keeping them on the waiting list. The only concern we have with that is that our policy doesn't give priority if you go downstage the patients. Now we have to put them on the list, then do the surgery and keep them on the list with the size of the primary tumor. and we do not transplant them if they're doing very well, even if they get a donor offer. We usually transplant them to rescue if they recur after resection.
Thank you. Move on the next paper. I think
Okay.
it's yours.
Okay, I haven't heard too many things about intestinal transplant in this meeting. That's why we will provide some insight about our evolution of a program and the lesson learned over the last years. As you all know, patients with intestinal failure require a multidisciplinary approach. The establishment of a multidisciplinary rehabilitation and intestinal transplant program was done in Argentina by myself in 2006 when we reached the intestinal transplant area and the challenge is to be overcome. This is a retrospective analysis of a prospectively filled database of intestinal failure patients referred to our center from March 2006 to February 2017. We didn't include the last year experience because this analysis wanted to prove longer time survival of more than a year. That's why we exclude the patients done over the last year. The number of patients evaluated, patients listed, indication for transplant, time on the waiting list, ischemia times, and survivals will be discussed in the paper, and we will divide the experience in 3 periods: 2006 to 2009, 2010 to 2013, 2014 to 2017. As you can see here, over these 3 periods of time, we have similar referral number of patients. You can see that the number of referrals was 100 and, let me see if that works. 105, 95, and 110. 310 patients in total. There was no significant difference over a period of time. Now it's interesting, we offer non-surgical treatment to a very similar number of patients. There was a difference between this one period and this in relation with the type of patients that were referred. But we offer surgical patients in an increased number of patients over time from 20 to 34. Although it's not significant, you can see that we are trying to rehabilitate more patients than we are trying to transplant them. Right now we have 4 patients remaining on the waiting list, and this is a very important point, is they have 3 highly sensitized, and the 3 of them are waiting for a retransplant. And this is one of the challenges that we have to face in the future. The indications for intestinal transplant over a period of time has been lack of central venous access, parenteral nutrition-associated liver disease, and catheter sepsis. That are the 3 main indications worldwide. What is interesting that over time, we found an interesting change because during the first 2 periods, most of the patients that we transplant have mainly parenteral nutrition-associated liver disease. Right now, the numbers are reducing, and this is the impact that it was seen in our program and around the world due to the changes on management of those patients with new parenteral nutrition solution and with new therapy to avoid and reduce the number of sepsis, catheter-related sepsis. And this pie changed, and we used to have liver disease as the main disorder, and right now is lack of central venous access is the main cause or reason for transplantation. 11.1 is the rate that the world has in most of other centers. As you can see here also, one of the major differences, you see an increased number of time on the waiting list. Why? We have close to 700 donors in Argentina, as I showed you in the talk before, and we have only 4 patients on the waiting list. The major problem for those patients are size mismatching, the blood type, and now the high sensitized patient. We don't transplant patients who have positive cross-match, and we do prospective cross-match, not retrospective. We go to harvest the donor, and we get the result of the cross-match at the time of the harvesting. Interesting enough, as you can see, the number of transplants also went down from 21 to 13 and to 8. And number of retransplants are growing, and now for the future, most of the patients that we have on the waiting list are retransplant patients. We have performed over time 34 intestinal transplants, 7 multivisceral, 4 combined liver transplants, and we have included also in 7 cases the colon, and in 15 cases the anterior fascia of the abdominal wall of the donor. There was no difference on total ischemia times, who are rounding around 7 hours and 50 minutes, and our warm ischemia time is around 40 minutes. When we look at survivals, you can see that even despite the fact that we are doing less transplants with a period of time, the survival at the first and third years are better in the later period, because we are improving also immunosuppression, but also because in the first era we received a significant number of patients that have been waiting for many years in Argentina to have the chance to be transplanted, and they were much more sick from the beginning, and was the number of patients that were requiring more multivisceral and combined liver bowel transplants in our experience. Now, 21 patients from all the whole experience has died over the years. Causes of graft failure and death were, first, severe exfoliative rejection, chronic rejection in 5 patients, hyperacute rejection, and if you can see, rejection accounts for more than 50% of the total number of deaths or graft loss. 2 PTLD, 2 primary non-function in multivisceral or combined liver bowel patients due to a liver primary non-function, and 1 case of graft versus host disease. Interesting enough, the cases with rejection, in 43%, the cause of the graft loss was non-compliance. Conclusion. Over the first 13 years period of the program, there has been a similar number of referrals with a steady reduction in the number of transplant evaluation and transplant performed due to an increased number of successful surgical and medical rehabilitation. The overall long-term survival has remained comparable to larger centers. Late graft loss has progressively increased, rising with the proportion of high sensitized patients on the waiting list, and now, over the last 4 years, we are measuring donor-specific antibodies in our patients, and we see that one of the major factors for late graft loss is the development of de novo DSA. The establishment of a closer immunological follow-up, new effective desensitization protocols, and new immunosuppressive strategies are some of the challenges that we face to improve long-term results. Now, this is our overview of the program. At the beginning, we transplant more and rehabilitate less. Over time, we have a significant increase of the number of patients who have seen us, an increase of the patients who have been on PN, a growing number of surgical rehabilitation with 83% of PN independency with surgery and non-transplant. And over the last 2 years, we have the largest experience in Latin America using glucagon lipeptide 2, a new drug that is used after surgery, even in patients who have only 20 centimeters of jejunum, and we were able to take them off PN with surgery and GLP-2 avoiding transplantation. Therefore, transplantation is dropping now as part of the strategy, but we have to look at the overall survival. Look, the survival on patients on PN right now at 5 years, 93%. When we do surgeries, 85.3%. Transplant patients, as you saw, was probably around 50%, but the cumulative survival of all the therapies, which is we are looking for right now, is about 75% at 10 years, and that is what the overall program should look for. Thank you very much.
Thank you. It is excellent work. Thank you. Any comments or questions? No? Thank you. Thank you.
Thank you very much.
And this is the last talk today. Attitudes and knowledge of potential organ donors, families, and nurses regarding transplantation. Antonia Kalli from Cyprus. Antonia.
Good evening. My name is Antonia Kalli. I'm PhD candidate in European University of Cyprus. This presentation is one of my part of my PhD. Several issues keep concerning us, such as organ transplantation, if one has the right to donate his/her organs, whether it is moral to become a donor while alive or after death, if brain death is identified with definite human of death. In the field of transplantation, families of potential donors and health professionals are faced with deceived decisions, choices, and moral dilemmas. Propose to explore the attitudes and the knowledge of the families of potential organ donors and of nurses regarding transplantation. Material and methods. This is a systematic bibliography review and investigate the attitudes and knowledge of the families of potential organ donors and of nurses regarding transplantation in the PubMed, CINAHL, UNBASE, and Concord's database. This is the main criteria for the inclusion of the studies in the systematic review at publication in English, qualitative and quantitative or RCT studies, but not reviews or meta-analysis. Qualitative research should include cross-sectional studies, interviews, phenomenological studies, publication within the last 15 years. Studies should be held in national or local level. Demographic and clinical results of the sample of the study, which are families or possible donors, nurses and nurse students, and the type of experience investigated. After 215 studies from the search strategy, 46 studies have been included. Out of the total studies, 19 studies were reviewed and are the ones which relate to the families of possible organ donors, relatives, or loved ones. The rest of them relate to nurse or student nurses. Even though the great majority of research show that both student nurses and nurses, as well as families of possible donors, are posed in favor of the organs donation, the lack of knowledge about brain death and donation procedures affect their attitudes toward donation. Information, education, and sensitive approach contribute to a change in attitude and lead to a conscience. Religion values, culture, and social demographic factors affect also attitude in favor of donation. Attitudes and knowledge of the families of potential organ donors. The main factors that could have deterred the families of potential cadaveric donors from giving their permission to donate organs are their non-acceptance of brain death due to ignorance of confusion of definition of brain death and donation procedures with the correct diagnosis of brain death, the fear of the account organ destination, religious beliefs, the lack of knowledge of potential donors' wishes, and the conviction of maintaining the integrity community body after death. However, altruism is often particularly intense in family members and is related to their desire to communicate with nurses and their willingness to offer to the community. Equally important are the positive attitude and behaviors regarding organ donation by families. In addition, it appears that the higher the educational level and the more people's understanding the organ donation procedures increase the possibility of conscious on organ donation. An important parameter is also the religious beliefs of families that may favor the positive attitude of the general population. As in Muslim countries, it is believed that organ donation is consistent with the doctrine of Islam. Finally, the definition of brain death is complicated and difficult to understand, and the relatives do not seem to fully understand its separation between coma and irreversible condition that is recognized as death. Indeed, some relatives and previously accepting to donate organ is the first instance to secure more time and hopefully their close person come back to life. Others are suspicious with donation and believe that will be given less emphasis to the patient potential donor's care. In a study in Spain, there was a positive attitude of nurses towards organ donation, that is 87% prior to education and 94% after completion. Additionally, 46 report incomplete training before being informed, and after training, 90% say they were able to reach families of potential donors. A study showed that 39% of the general population in Qatar were willing to donate their organs after death, with only half of them willing to donate organs while still alive. Appropriate education and training is essential. The knowledge is commensurate with education and experience. Education programs should be upgraded and focus on the message of religious legitimacy of the deceased organ donor. In addition, the attitudes has been found to be positively correlated with the knowledge of brain death, brain donor donation, as well as the promotion of donation in practice. The more positive the attitude of nurses, the more they will raise the question of donation. A particular problem is, however, found in the knowledge regarding brain death, which is prerequisite for transplantation, as it seems to be related to the negative psychology of nurses in the field of transplantation. According to results of the studies, the increase of knowledge also creates a more positive attitude of nurses towards organ donation and transplantation. Nursing student. A survey carried out in 2009 at 3 nursing schools in Spain found that 70% of the students had sufficient understanding of the concept of brain death. 27% had doubts, and 3% believed that the person who is brain dead is likely to recover in life. Therefore, there is a lack of knowledge, confusion, and doubts about brain death. Also, according to another study, nursing students, as well as future health professionals, should know that they have the responsibility to approach a family of brain dead potential organ donors and reach their concern to donation in order to increase donation and organ transplantation. Instead, a survey concluded in New York found that 20% of nursing schools failed to teach students how to approach a potential donor family about the possibility of organ donation. According to nurses' opinion, roles could be classified as public awareness, care for the recipient, donor, and their families. Nurses must be sufficiently trained, especially for such situations. Before a training program, 46% of students say they had incomplete training, and 90% say they had the ability to approach the families of potential organ donors after the training they had. They also argue that educational awareness should be improved to increase organ donation for future health professionals. Another study supports that the religious effect was considered as an incentive and support factor for families after conscious on organ donation. Religious beliefs have an important role in decision. Based on the important role that nurses have in the organ donation system, nurses should receive adequate training to understand the process and reach out to potential organ donors and their families, informing them and meeting their needs. Therefore, the creation of effective education programs in universities can affect knowledge and attitudes, and consequently the tendency for organ donation. Conclusion. The review has highlighted that in families of organ donors with positive attitude, altruism and brain death wishes dominate as a reason for conscience. Religious influence is considered as a motive and supporting factor for the family after the consent to organ donation. Communication and informing relatives subsequently increase the emotional support of relatives and the positive attitude of families, organ donors, and transplantation. Education contributes positive to modifying views and the attitudes of the families of potential donors. Thank you.
Thank you very much. It's very good effort and very good study. I think we same point, continue education with the patient is maybe solve the problem, organ donation problem.
Yes.
Any question and comments? Dr. Haberal?
Well, congratulations.
Thank you.
Listen, nurses and nursing activities is very important. I'm always saying that. as a surgeon, what we are doing now, operating, for instance, liver transplantation and bringing patient to ICU and, you know, making round the morning and evening, rest of them belong to you. Therefore, you know, so your activities is very important, as always. Therefore, you know, when I founded university, Başkent University, I opened the first in the nursing school. And then I decided that at that time, you know, nursing school, high school, and I thought that the nurses should be, you know, educated from faculties. Therefore, you know, I established that the first time in Turkey, you know, healthcare and the faculties, and now is the or nursing in the, you know, the graduated from faculties as well. Therefore, you know, it's, your activities is very important. I'm always appreciate you and your presentation also excellent. Thank you so much.
You're welcome.
This was the last talk of this meeting. I think we have closing ceremony at 6:10 in Dolmabahçe Ballroom. Next door. Anything? We would like to thank all the speakers. Thank you very much, sir. Thank you.